So what we're going to do today is we're going to finish up chest x-ray. So the first half of this, what we're going to do is we're going to go back through, or not back through, but we're going to talk about chapter 2 again and try to finish that up as much as we can. And then we'll take a break and we'll come back and we'll do the rest of chest x-ray. We'll kind of review PA and lateral, dial it in a little bit tighter, and then we'll talk about all the other views that you're going to have to know about chest x-ray. I'm going to try to simplify that a little bit for you as well. So we talked about lines and planes last week, but we also need to talk about body cavities. Essentially, we've got two major body cavities, and then one of those is broken down a little bit further. So the two great cavities will be the thoracic cavity, and that's everything that will be above the diaphragm. So that will be your lungs, your heart, the things in the mediastinum, your trachea, great vessels, and all of that. So that will be in the thoracic cavity, and the abdominal cavity contains pretty much everything else. So the abdominal cavity is subdivided into the abdominal pelvic cavity in a lot of cases, meaning that we've got a subcategory of abdominal and a subcategory of pelvic cavities, but it's really the abdominal pelvic cavity. It's the abdominal cavity. So in the thoracic cavity, what we have is the pleural membranes. We talked about those before. We've got, it's a double-walled membrane. You've got your parietal pleura and your visceral pleura, the parietal pleura being what's in contact with the kind of the chest wall. And then the visceral pleura is what is in contact with the lung. And where we have issues, in the pleural cavity is when we have fluid inside the pleural cavity, and that's what we refer to as a pleural effusion. So we're going to talk about pleural effusion and how we diagnose that here in a bit. But also, if you have air that's in the pleural cavity, you got a problem. Both of those cases will cause the lung to collapse. So when you have air in there, that's what we refer to as a pneumothorax. It's air, pneumothorax. It's in the thoracic cavity, but it's not where it's supposed to be. So it's pneumothorax. In both of those cases, it causes the lung to collapse. And you're going to have a tendency to look at either a chest x-ray or look at a question on a test, and we're going to say, maybe the question reads, what is a condition where you've got air in the pleural space? What's your answer?
Pneumothorax.
Pneumothorax, right. But what does pneumothorax cause?
Collapsed lung.
Collapse of lung, right. So then you may have another question that says, what is a condition, what do we call a condition of a collapsed lung? What do we call that?
Pneumothorax.
No, actually we don't. The collapse of the lung is the result of the pneumothorax, but the collapse, what's that? Atelectasis. Atelectasis is the actual collapse of the lung. So you can have other things that cause a collapse of the lung. Pleural effusion, the fluid is going to displace the air that's in the lung, thereby collapsing the lung, but you don't have a pneumothorax. Pleural effusion is fluid in the pleural cavity. Pneumothorax is air in the pleural cavity. The resulting collapse of the lung is atelectasis. So collapse of the lung, atelectasis, all right? What's causing the atelectasis? Is it fluid? Is it air? What's going on there? All right, so we have pleural membranes. We have the lungs, we have the trachea, we have the esophagus. The esophagus is posterior to the trachea. We've got the pericardium, pericardial sac, and we've got the heart inside of that. So we've also got the great vessels. So we've got the inferior vena cava coming up from the bottom, superior vena cava coming down from the top. We've also got the aortic arch where the aorta comes out of the heart. It makes essentially a 180-degree turn, and it goes down and it becomes an abdominal aorta, and then it divides into the iliac arteries. So abdominal cavity, what we've got is peritoneum. That is the lining of the abdominal cavity. We've got the liver, which is the single largest organ in the system. We've got the gallbladder, and the purpose for the gallbladder is just to store bile. So we create the bile in the liver. Incidentally, the liver has a ton of functions. It's like 1,000 things that they've identified the liver to do. So it's a major organ. The gallbladder, it receives bile, which is one of functions of the liver is to create bile. So the gallbladder receives the bile, and then it pulls water out of it to concentrate it. So it receives, stores, and concentrates bile. Pancreas has a lot of different functions as well. It is both an endocrine and an exocrine organ, meaning that it secretes into the bloodstream, like that's where you get your insulin, but it also excretes into the small intestine, and we'll talk about that more next semester. You got the spleen, just a big blood and lymph reservoir right over by the stomach. The stomach primarily being on the patient's left-hand side, depending on anatomy and the body habitus of the patient. Then, of course, you got your intestines. Your kidneys are in the abdominal cavity, but they're retroperitoneal, meaning that they're behind the peritoneum. You got your ureters and major blood vessels there as well, we already talked about. So, in the pelvic cavity, we've got the rectum, the urinary bladder, and part of the reproductive system, especially in women. All right, so when you're taking a history on a patient, you need to identify where the patient's issue is. So it's not just enough to say the patient has stomach pain. Where is the stomach pain? So you have to be able to, not really pinpoint, but describe the area where the pain may be. And there's two different ways that we can do that. Most commonly, we're going to use the quadrants. So what is quad? Four, right. So we have 4 portions or 4 areas in the abdominal cavity. And in the perfect abdomen, the umbilicus, the belly button, would be right in the middle of that, right? So you'd have a line going up and down the patient and then one going across the patient. So you divide it into 4 sections. What you'll find is some people, their belly button may be a little off center. So that's why I say a perfect world. So those are your quadrants, and they're just named using medical terminology where they are, right? So you've got one that's top right, top left, lower right, lower left, okay? Right upper, right lower, left lower. Quadrants are good for probably 90% of your histories will fall into the quadrants, but sometimes you need to be a little bit more specific. So we said that in a perfect world, the quadrants were divided at the belly button, right? Well, what if you have belly button pain? What if your pain is right there? And they say, you ask them, where is your pain? They say, right at the belly button. How do you describe that? Pain at the junction of the 4 quadrants. Right?
So right in the crosshairs.
Yeah, well, you could say right in the crosshairs, but if you look at the pictures on page 50, you've got your quadrants and you've got your regions. So your regions, there's 9 different regions. Now, the most common one that you're going to use would be, common ones that you would use would be those right at midline. So even if you have what we refer to as hypochondriac pain, which is left and right, colic pain, right? Then, we could put those in quadrants, but could you put epigastric pain in a quadrant? It'd be tough to, right? Could you put umbilical pain in a quadrant? Not really. So if you have a epigastrum, you're going to have a hypogastrum too. So your lower region in the center would be your hypogastrum. Okay. If you look on the next page over at 51, you're going to want to put a marker in your book, paper clip on top. We're going to refer back to this throughout the semester. So it's, we're taking x-rays of things we can't see. So we're taking pictures of things we can't see. So we have to have something to identify where it is that we want to put the central ray. External landmarks representing internal things. All right, so I'm going to take just a short break from that. I'm going to ask you to turn in your book to page 103. It says PHS X-ray. So PHS X-ray, for each one of these projections, what you're going to need to know is where to put your central ray, where to put your image receptor, if there's some sort of other tips to put in the image receptor. what it is that you need to see, what's the best position, body position to have the patient in to make a diagnosis, okay? So central ray location is huge. For everything that we cover, you're gonna have to know central ray location. And that sounds complicated, right? For every exam that we shoot, we need to know where the central ray location is. Sounds complicated, it is, because we're gonna go through, you know, upwards of 100 different projections in this semester. So it sounds kind of tough, doesn't it? And it's not really, if you just apply a little bit of common sense. So what do you want to see on a chest X-ray? You want to see the lungs from top to bottom, left to right without rotation. That sums it up. That's what you want to see. Now you identify what is at the top. What's apex? What's at the bottom? Costophrenic angles. How do we identify rotation? Well, we'll take a look at that here in a minute. So that's what you want to see. Where you want to put your central ray, what does it say?
T7.
Yeah, T7. So how many thoracic vertebrae do you have? You've got 12, right? So they get bigger as they go down. They're smaller at the top. They get bigger as they go down, right? So if you put it at 6, or even the interspace between 6 and 7, you're still a little bit high, right? Because your vertebrae are getting bigger as they go down. So T7, pretty much right dead square in the middle of the lungs on most people, okay? So apply that to upper extremity. Where do you suppose our central ray is going to be for our forearm? 3 words, right, dead, square, well, 4, center, okay, all right? So you just got to identify then, you know, because your central ray is always going to be to the middle of the anatomy of interest, and you just got to then identify that anatomy of interest. With chest X-ray, it's going to be T7. So if you flip over now to page 106, under central ray, what does it say?
Perpendicular to the
At the level of
T7.
T7, bingo. So now we're going to flip over to page 109, and central ray location is?
Perpendicular to the center of the IR.
At the level of?
T7.
T7, right. So now we're going to, and incidentally, we're not going to cover obliques. You're going to shoot a lot of obliques because you're going to mess up positioning, but we're not covering obliques right now. All right, so then we get to AP chest. So this is AP supine. If we can't shoot the patient upright and we can't sit them upright, and it happens, especially on portable exams, 2 things. This is exception to 2 things. One is sometimes we have to shoot them supine, laying down, have 40 inches. Okay, most of the time we want them upright. But at any rate, they complicate this just a little bit, but notice where your central ray location is. Central ray should be approximately
3 inches below the jugular vein.
Yeah, so we're going to look back at our chart here in a minute, see if that's represented. So what have you learned just in positioning a central ray for chest X-ray? What's the commonality there?
Should be in this
Central ray should be perpendicular to T7, right. So do you have to file that away with every projection on chest X-ray that we shoot? You just know it's T7, right? So we'll flip over to page 120, and do you see the same thing there? Page 120, did I say 120? Yeah.
Yeah.
So T7, right? But what does it go on to say? If you're shooting AP, it's going to be
Jugular.
3 inches below the jugular notch, which would correspond to
T7.
T7, right? So every one of these are going to be T7, with the sole exception of page 116. We're not looking for the entire lung on 116. So our central ray location, in a practical sense, is going to be in a totally different place. First off, we don't need to see the entire lung. We don't need to see the base of the lungs. We just need to see the apex. So our image receptor size is going to be smaller. Our central ray location, even though it's saying 8 to 10 centimeters below the jugular notch, you're changing the position of the jugular notch on this, okay? So you're not going to center really truly at T7, it's going to be a little bit higher. And the only thing that you want to see is the apex of the lungs. And so we'll talk about that in the next hour. So central ray location, unless I say apical, lordotic, apiaxial, I'll define what that is. Where is your central ray location for chest X-ray? T7, right. All right, so I just kind of drifted off on that because it caught my eye. All right, so surface landmarks was where we were going anyway. So again, mark that page. So in body habitus, we touched on this last week a little bit. In body habitus, we have to be able to compensate for you know, the position, the shape, and the size of the patient and their organ systems within their body. So the things that are going to be affected by body habitus, heart and lungs. The lungs are going to have a tendency to be shorter and broader, more broad. The heart is going to ride a little bit higher. The diaphragm, likewise, is going to be a bit higher. The stomach is going to be in a patient with that is hypersthenic. The stomach's going to be high and transverse. That's not the entire stomach, but the same thing with the colon, the gallbladder. All of that is how body habitus is going to affect hypersthenic. If you have asthenic, all of this reverses. So what you've got is a heart that's very kind of low, and the lungs are very long. The diaphragm is very low. The stomach is very vertical and predominantly on the left-hand side. In a hypersthenic patient, it will be more centrally located. The colon is going to be, you know, longer than what it is wide, and the gallbladder is going to be very close to midline, and a lot of times very low in an asthenic person. So it can affect how you need to position the central ray and how you need to position the image receptor. Okay, so you have the 4 basic body habiti. We talked about that last week. Okay, so we're going to skip over osteology, and we're going to pick that back up when we start upper extremity. There's no reason for you to know these essentially for this test. Arthrology, even for the next test, we're not going to get real specific on. If you find it on the registry, it's going to represent such a small portion of the registry, you know, the joint types and whatnot. So we're going to skip all the way over to anatomical terms and dial all that in. Okay? So we're picking up on page 65 here. All right, so a couple of different words for the front of the body. One is anterior, you know that, also ventral. You think about when you breathe, you watch somebody breathe, most of the time you can see their chest and their stomach coming in and out, right? So you don't really see the back expanding, but you see the chest and the stomach coming in and out. So, you know, word association, ventral, front, that's the anterior portion, it's ventilating. And posterior would be the dorsal, and it gets a little bit complicated in different anatomy. So the dorsal portion is the back portion. So think a dorsal fin on a shark or dorsal fin on a dolphin or something like that. It's a thing that sticks out of their back. It's a dorsal surface. Dorsal gets a little bit more complicated when we get into lower extremity. It actually refers to the top of the foot, which looks more like the anterior surface. Well, it is anterior surface. So it's almost like a contradiction. You're anterior, yet you're dorsal, but they refer to that as a dorsal portion of the foot. So caudad is away from the head, and then cephalad will be towards the head. So sometimes we need to utilize central ray angulation to desuperimpose things. If you remember, superimposition is where you've got 2 things stacked, right? So there's 2 ways to destack things. And that is essentially rotate the patient to try to get things off of each other. Like, for example, my heart is primarily on my left-hand side, right? And is covered a little bit by the spine. So if I put the 2 together like that, I've got spine and heart. But what if I need, not everybody can see, but I'll do this from the other direction. So what if I need to see my heart without the spine over the top of it? We could oblique the patient. So that's one way. Another way is, so I'm gonna do this, so I'll do this. So we go oblique and remove that superimposition. Another way would be to angle the central ray. Okay, so we might angle the central ray towards the head, and what we would refer to that as is a cephalad. Cephalic angulation, as opposed towards the feet would be a caudal angulation. Okay, so and we'll talk more about that as we've got some specifics in that as well. So superior, near the head. So there's a lot of commonality in some of these. Can y'all see that okay, or do I need to change the color? You're good? Okay. So inferior is nearer to the feet. Central, just as it sounds, mid area. Peripheral would be away from the central, so it's out, out distally. So peripheral, distally, kind of the same thing. Your periphery would be away from your midline, towards the lateral side. Medial would be towards median. Lateral, again, would be towards the outside. Superficial is pretty, and deep are pretty obvious. Superficial, you think of somebody who's superficial, they are?
Shallow.
Shallow, exactly. So you got shallow versus deep. Superficial being near the skin is shallow, and deep is the exact opposite of that. So distal, furthest from the point of attachment. Now we're getting a little bit more specific. So you got your distal, let's say your hand is distal to your elbow, elbow is distal to your shoulder. Proximal is the exact opposite. Elbows proximal to the hand, right? The hand is proximal to the fingers. External and internal, pretty obvious. All right, so we've got parietal and visceral. And we've talked about that in the pleura. So the parietal is the lining of the body cavity itself, as opposed to the visceral being right on the organ system. So in your pleura, you get your parietal, visceral. These two are opposites of each other. Ipsilateral means on the same side of the body. So, if a patient complains of pain in the right ribs, and they've got reddening, swelling in that area, that would be ipsilateral. So intake and histories for a lot of years, I can think of exactly 0 times I ever used ipsilateral. But contralateral, you do actually use. So a contralateral injury would be, let's say the patient got hit, T-bone accident on say they're driving, so they get hit on the left-hand side, and maybe they got some pain on the right-hand side. Okay, that would be contralateral. Somebody gets hit in the head, or maybe they're in a car wreck and their head bangs into the window, and they have this big knot on the right-hand side, but they've got some pain on the left-hand side. Maybe their concussion may be on the right-hand side. So that would be contralateral. Palmar, just as the word implies, is palm of the hand. Plantar is the bottom of the foot, where the dorsal portion is top. Then the sole of the foot is the plantar surface. And you can just think of that as, if you ever played any kind of sport and you were getting ready to run a sprint or whatever, what would the coach say? Plant your foot, right? Plant your foot here and there, and get ready to sprint or run, whatever. Dorsum is again the anterior portion of the hand, or the anterior portion of the foot, or the back of the hand. I'm sorry. All right, so we talked a little bit about the difference between projection and position last week. So position, we got a lot of things. So the patient can be upright, that's a body position, right? The patient can be seated, that's a body position. The patient could be on a stretcher and semi-upright, that's a body position, right? So sometimes our positions and projections, a projection is the path of the x-ray beam, what it hits first and what it hits last. Like a PA projection would be with the x-ray beam behind the patient, generated behind the patient, and it hit posterior anterior, that's PA projection. All right, so sometimes our positions and our projections can kind of bleed over into each other or have specific implications, right? So when we do a chest x-ray, we usually do a PA projection and a lateral projection, so we get that 3D perspective of that two-dimensional image. So we do PA and lateral. The lateral is both a projection and a position, okay? Almost always left lateral. There are conditions where we might shoot right lateral, but almost always left lateral on chest x-ray. That puts the right ventricle closer to the image receptor. If they're concerned about a nodule or something in the right lung, we might do a right lateral. Well, there are two conditions where a patient has their heart on the wrong side. Okay, one is what we refer to as decubitus. That just means the heart's flipped around. All right, and the other condition, the patient tends to have a lot of other health issues to go along with it, but that's where all the organ systems are flipped around, and that's what you refer to as situs, S-I-D-U-S, situs inversus. Okay, so in those cases, if you know your patient has dextrocardia or situs inversus, you would shoot a right lateral. Otherwise, and that's a very small portion of the population. Otherwise, you're going to shoot a left lateral. So projection, path of the x-ray beam, position can imply a lot of different things, including some projections. We're going to talk about decubitus positions and what all that implies. Decubitus just means laying down. By the strictest definition of the word, decubitus just means lying down. When we're referring to decubitus and positioning for x-rays, we're going to take the definition a bit further and describe it a little bit differently as well. So view or method are two other things that we might refer to. So a view is the perception of the image, essentially. So it's from the perception of the image receptor. So if we're shooting a PA projection, then what that would be is an anterior view. Okay, so your image receptor is here, and it's looking at the front of the patient. And if I just, drummed on the mic and it comes through real loud, I apologize for that. But at any rate, that would be an anterior position, all right? Sometimes also, I'll kind of refer to a little bit of a view. It's probably best described as a view. Or a description of a view, and that is, I'll say, like a frontal view. Okay, and what I'm referring to there is anything that gives you the height, the height of the lungs and the width of the lungs, and we're looking at it as if it's been shot AP or PA. Okay, that's what I mean by frontal view. You don't really see that in textbook, but it's all encompassing. So, if I mention that. And then a method is something that's been developed by a specific individual. So it's a view that with a projection that has been developed by somebody. When we get into skull work next semester, most of those either do have or have had views associated with them. Caldwell, Waters, things like that. We're going to talk about some things this semester that also have view listed, like when we get into hips. One of the views of the hips that everybody hates is what we refer to as the Donnellius-Miller method. And that is what you're going to find out in clinicals is cross-table lateral hip for a patient who's got a broken hip. And they're kind of tough. So anyway, that would be a method. So central projections, you're going to need to know where the central ray is, where it enters the surface landmark, what you're lining up to. AP refers to the central ray coming into the anterior surface, exiting posterior. PA is the exact opposite, enters posterior, exits anterior. And an axial means that we've got a central ray angulation with the longitudinal axis of the patient's body with 10 degrees or more. All right, so a lot of words to say this. If you've got an angulation, say this represents my central ray. If you got an angulation of 10 degrees or more going this way, that's an axial, okay? So you can have an angulation, you know, with a pretty steep angulation, maybe as much as 50 degrees. And we'll look at that again when we get into the head next semester. But most of your angulation is going to be pretty shallow, 20 degrees, 25 degrees, maybe up to 30, but they're going to be relatively shallow. So that's axial. All right, you're going to have a tendency to confuse axial and tangential. With a tangential, you might have a central ray angulation, you might or might not, but with a tangential, what you're doing is you're skimming the surface of something. So it's not exactly an axial. It could incorporate an axial angulation, but in a lot of cases, you can actually oblique the patient to get to a point of tangential. For example, a knee is something we're going to go through you know, in lower extremity in a few weeks. So in order to visualize the knee, the problem with the knee is that you've got the femur and the fattest portion of the femur right over the kneecap. So if you need to see the kneecap, you need to see it by itself, right? So you can see it a little bit through the femur, but it's not real clear. So we've got a view that we do where we take the patient and we bend their knee. Providing it's not broken, we've got to diagnose the fracture first, but if it's not broken, we can bend their knee. Now the kneecap's sitting right out here. Does that make sense? Mm-hmm. So in order to visualize that kneecap, what we're going to do is we're going to take our central ray and we're going to send it so that it just skims the surface of the knee and it takes the kneecap and puts it on the image receptor all by itself. That's a tangential, okay? Cheekbones. What forms your cheekbone is this little bitty skinny bone, it's smaller than your pinky finger, that goes and it connects two different bones. And in all views of the skull, except for a tangential, you can't see it all by itself. You can see it superimposed on things, but you can't see it by itself. But we can do some things to skim the central ray just right through the gap between that bone and the rest of the skull in order to see the cheekbone all by itself. Tangential. Skims the surface. Axial, pretty steep angulation with a long axis of the body, okay? So, and again, tangential may incorporate angulation of the central ray as well. So lateral, we've kind of talked about. Oblique is, you know, somewhere between PA and lateral, so the patient's turned a little bit. So the oblique projections and positions are going to be pretty specific. You're going to have questions on the test that you're going to want to attribute to projection and some that you're going to want to attribute to position. And what I mean by that is, let's say we do oblique of the chest. It's registry testable, you know, obliques of the chest, but Amy's going to cover it in the second year. We just don't do a whole lot of them. So if I'm standing here and central ray's back there, what is my projection? PA. Okay, what's my body position? I'm upright and I'm, from the point of view of the IR, it's an anterior position, right? So let's say I do an oblique. I turn, let's say 45 degrees. Okay, where's the central ray hitting first? Okay, shoulder, but really kind of, I mean, is it hitting side of the shoulder, front of the shoulder? Posterior. Right, so am I still in a PA projection? Yeah. Okay, so this is still a PA projection, but where I am is, what shoulder is that one? Left. Which side is up against the image receptor? Anterior, and I'm not PA and I'm not lateral, so I am oblique. So what this will be referred to as a right anterior oblique. That's a position, PA projection. Okay, PA projection, right anterior oblique. So, what's this?
Anterior.
No,
What, you said the position or projection?
Okay, let's start with individually. What's the projection? AP. It's AP. What's the position? It's oblique, but specifically it's going to be I'm getting right and left.
Left posterior.
Which hand is this?
Right.
It's right,
Right posterior.
posterior oblique. Okay, so we're going to shorten that to this is RPO. If this is RPO, then this is LPO, right? So this is LAO, and this is RAO. Okay, so now when we get to the test, all semester long, don't be afraid to position yourself in your chair and mentally lock in. Okay, my table is my image receptor. The central ray is coming from behind me. If it asks you for an oblique, just oblique yourself in your chair. Okay, I'm saying that, and I've got 33 people in the room saying there's fat chance I'm doing that. By mid-semester, y'all gonna be all over the place because you missed one too many times. Okay, you're gonna be positioning your arm. Okay, don't be shy. You're gonna be together for 2 years. Get it out of the way now, right? You're gonna be doing it sooner or later anyway. I see people kicking off their shoes and looking at their feet during tests. It's like, whatever works for you. All right. So again, you've got AP. This is AP axial. PA, that will be a tangential. This would be actually a superior inferior, which we haven't even talked about. When we get into skulls, we'll talk about that. Again, lateral. So general body positions, we've got upright, seated, recumbent. This patient can be supine or prone. We've got other words for really all three of those. Those would be decubitus. If the patient is laying on their side, then that would be a lateral decubitus position. And our central ray, if it's coming from the front or the back, will be an AP or a PA projection. We'll take a look at that. Supine versus prone, patients looking up. So word association up. Patients laying on their back and they're looking up at the x-ray tube as opposed to prone is laying down. Trendelenburg is a specific position where the patient's laying on their back, but their head is lower than their feet. And the Fowler's position is with the patient in some sort of seated position. So the patient is laying down and their head is elevated. So you may hear the Fowler's position more described as the patient sitting up with the bed. And then a semi-Fowler's position is the patient laying back more. So you may see that, but the strictest definition of a Fowler's position is pretty much the opposite of Trendelenburg. Where we would use Trendelenburg is, let's say a patient faints and they're on a stretcher, we could elevate their feet, lower their head. But we've also got some pathologies that we can demonstrate with Trendelenburg we're going to look at next semester when we get into GI work. If a patient has a hiatal hernia or something like that, or possibly gastric reflux, they've drank some barium, chased it with a little bit of water, we can put the patient in Trendelenburg. In a lot of cases, we can see that those conditions a little bit better. Okay, so anybody observed a BE? No? Are you in for a treat? Okay, so what we have to do with a BE is we have to fill the colon up with barium. So we've got, what we'll do is we'll take, I'm not going to demonstrate that because it's kind of creepy. But anyway, the patient from a left lateral recumbent position, they're laying on the left-hand side, what they're going to do is they're going to bend their right leg and put it anterior to the left leg and roll into a semi-prone position. That will be a LAO position, right? We're not taking any x-rays in that, but that's the best position to put the patient in. They have a stable foundation. You have access to the proper parts, and that's the position you put the patient in to insert the enema tip. So you'll get used to that. But that's when they put the enema tip in, that's the position they put them in, is the Sims position. So lithotomy position, you're not likely to see this except for in two places. One is if you go to surgery and they're doing some sort of urology study. Maybe they're putting a stent into the patient. The stent would go from the bladder all the way up into the kidney. So they have to have access. So that's putting them in the stirrups, kind of like, if you happen to be a mom, you know what that means, right? If you've ever had a pelvic exam, you know what that means. They'll put them in the stirrups. That's the lithotomy position. And lateral, again, is with the patient's side closest to the image receptor. And it's named after which side is closest to the image receptor. Left lateral means either the patient's laying on the left-hand side or they're standing with their left side against the image receptor. Oblique, we've kind of done to death. Decubitus. All right, so decubitus. Strictest definition of decubitus is the patient's laying down, okay? But we're going to use it for other things as well. So the patient's laying down, and we do exams with the patient, a lot of exams with the patient in a decubitus position. But when we call it a decubitus, it implies two things. And I don't think this has worked well in the past, but okay, can you kind of see where the water's sloshing?
Yeah.
Okay. If my light was coming straight down onto this, and I can't turn this and show this to you, but if it was coming straight down on this, would you be able to see the water level? No, you would not. So in a decubitus position, and since we're doing chest x-rays, I want to describe this now. If we need to see air fluid levels on a patient who can't stand, then we have to do something to demonstrate those. So our preferred body position is with patient upright in some way, with horizontal central raise, 72 inches for chest x-ray. Sometimes we can't get that. If it's a trauma patient, then we can't ask a trauma patient to stand up, right? But with a trauma patient, they may have a pneumothorax, so we need to see air. If it's an older patient who's been really, really sick and they have a pleural effusion, then we need to see, we need to see fluid. So if they potentially have pleural effusion, we need to see fluid. If they have pneumothorax, we need to see air. Neither one of those is going to show real well with the patient laying flat on their back. So a vertical central ray, patient flat on their back, is just not going to do us a whole lot of good. So we have to have a horizontal central ray. The problem is if my central ray is coming from there and I'm laying flat on my back, what am I going to have as far as one lung versus the other? You're going to have magnification, yeah. Superimposition, one's on top of the other. So how do you know which lung has the pathology? Which lung has the free air versus which lung has the fluid? You can't make that diagnosis definitively. So what we're going to have to do is we're going to have to roll the patient onto their side. Now you're going to have to kind of tilt your head a little bit and imagine I'm laying on my side. If I have fluid, where is that fluid going to go? It's going to go to the lowest portion, right? So the fluid's going to go, if the image receptor is over here, the fluid's, and I'm laying on my side, the fluid is going to go down, right? Providing we suspect that the pleural effusion is going to be in the right lung. Okay, so in order to see that fluid level, then I need to see, just like on this cup, how we saw the fluid level. How is my light? Kind of, sort of. It's horizontal, right? So anytime we're talking about decubitus, we're talking about a number of things. One is patient's laying down. Two, the patient's going to be laying on a specific side. It's either going to be a left lateral decubitus or right lateral decubitus. We can do either a ventral or a dorsal decubitus if the patient just absolutely cannot roll to either one of those. But that's the last case scenario. Worst case scenario on a really bad patient, we can't move. Okay, so file that away. That is an option, and it's testable that you could do a dorsal decubitus if everything else failed. But we want to do left or right if at all possible. Always implies, in radiology, it always implies a horizontal central ray. Okay, so if you get an order for a decubitus chest x-ray, that doesn't mean put the patient on the table and shoot vertically into the patient, right? That means put the patient on the table, lay them on the applicable side, and use a horizontal central ray. Okay? Now, let's dial it in a little tighter because we got to get there today. If I'm looking for a pleural effusion, okay, and again, a central ray, I'm looking for a pleural effusion. I suspect it to be in the left, or in the right. I told you, yeah. You're gonna forget which way to go, left or right. So if they suspect that it's in the patient's right lung, which side am I gonna lay the patient on?
The right side.
The right side, right. Because if they lay him on the left-hand side, even though the pleura, the visceral pleura, parietal pleura, even though it covers everything, if you lay the patient on their left-hand side, all that fluid's just gonna go towards the mediastinum, okay? What are the structures in the mediastinum? Heart, great vessels, right? So you're gonna put water on water. Are you gonna be able to visualize that air fluid level? No, you're not. So if I suspect the patient has pleural effusion in the right lung, I'm gonna put the patient on the right-hand side, okay? So if I have a patient with a pneumothorax though, where's the air gonna go if the patient has a pneumothorax? Is it gonna go up or down? It's gonna go up, right. So if, let's say, I've got a patient who's got a pneumothorax in the right lung, which side am I gonna put the patient on?
Left.
The left side, exactly. So for fluid, we're looking for the downside. For air, we're looking for the upside, okay? All right, so a lot of things for decubitus. Lordotic just means leaning backwards. That one view that I was talking about earlier that did not have central ray at T7 is our lordotic. It's apiaxial, apical lordotic. Okay, so body movement, we're going to talk about that later in the semester as well. Any questions on all that?